I was asked to speak about what is the virologic support for two-drug regimens, and let me start off by saying you can't really rely either on first principles or on in vitro data to support the two-drug regimens. It's all about the empiric observations of how these regimens work in people. These are my disclosures. So just to remind everybody, why are we using 3 drugs? Well, we stumbled onto 3 drugs, and we stumbled onto 3 drugs because after trying with 1 and 2 drugs, which weren't terribly successful, we eventually struck gold with 3 drugs. And remember, one of the very first 3 drug regimens was AZT, DDI, and nevirapine. And for the first time, we were able to actually get a substantial number of people suppressed. And the reason it took 3 drugs was that was based on the dynamics of viral replication, that approximately half of the population in plasma is cleared and replaced every day, allowing for very high turnover. And so in the presence of selective pressure, you see very rapid emergence of drug resistance. And if you take the drugs away, you can see the rapid replacement of resistant virus with the residual wild type. But the resistant viruses that were selected during the time of exposure persist in the reservoir and can come back if you reintroduce the drugs. And so the 3 drug regimens provided more durable virologic suppression, and many of the models, especially those generated by John Coffin and others, suggested that 3 drug regimens were necessary to prevent the emergence of resistance. And previous 2 drug regimens that included non-nukes or PIs with low barriers to resistance failed. And I mean regimens such as what Anton was showing when, remember, the pivotal trial for indinavir also included, for efavirenz also included an indinavir-efavirenz dual regimen, and that was pretty much a disaster. And even some 3 drug regimens were vulnerable to pre-existing resistance to a single component of that regimen, as is shown here from our data from an ACTG trial that looked at zidovudine 3TC and efavirenz. This is in the era before we were doing pre-treatment resistance testing, so we went back and retrospectively analyzed baseline samples and found NNRTI resistance in a proportion of the participants, and those who had a 181C or a 103N mutation were about 2.5 times more likely to fail than the people who had no transmitted resistance. Now, I should say, even though we relied a lot on models to justify the use of 3 drugs, and although Alan Perelson is really a leader in the field and somebody I respect greatly, let's not forget that Alan Perelson also created models that said that it would take at least 3 drugs to be able to cure hepatitis C, and we know now that 2 drugs is perfectly adequate in many settings to cure hepatitis C. So the models have to be always verified against reality. So the goal of therapy, in addition to being able to suppress virus replication in order to restore immune competence and maintain health, has always been to prevent drug resistance, because only by preventing drug resistance can you be assured of sustained virologic response and therefore of a sustained clinical benefit. And the way to prevent resistance was to use potent, fully suppressive regimens to avoid selecting resistant virus. But there's nothing in this concept that says how many drugs it takes to do this. It's just as long as you can achieve and maintain full suppression of virus replication, then that's the right number of drugs. Also using resistance testing where appropriate before starting treatment in order to avoid inadvertently providing fewer drugs than you expect, and avoiding virtual monotherapy when adding newer drugs to a failing regimen became an important principle of how we were managing switches in the setting of treatment failure. Well, this whole paradigm began to be turned a little bit upside down when we started looking at issues related to resistance to the nucleosides and transmitted nucleoside resistance or pre-existing nucleoside resistance in the face of more contemporary regimens. I showed you data that if you had transmitted non-nuke resistance, a triple drug regimen failed, but the converse was not necessarily true. If you had resistance to the nucleosides in the setting of an NNRTI resistance, NNRTI-based regimen, Anna Maria Giretti showed very nicely that actually it had little impact because the non-nuke was sufficiently potent, and the impact of the transmitted nuke resistance, which here are mostly TAMs, so it's mostly resistance to zidovudine, and now people were mostly using tenofovir. There was actually no significant difference whether you did or didn't have pre-existing nucleoside resistance, and although there's no randomization between the PIs and the non-nukes, the non-nukes came out better, even with transmitted nucleoside resistance compared to the boosted PIs, which was probably largely a tolerability phenomenon. Now, in thinking about the use of dual regimens and the virologic basis, one of the reasons why people began to be encouraged about using two drugs is that when you used boosted PIs as single drugs, although they were inferior to triple drug regimens, they weren't so terrible. They did pretty well. You had some greater failure, as you see here from this initial study by Jose Arribas, that with monotherapy you only achieved 81% suppression. This is a switch study compared to maintaining suppression in 95%. But very few of the people who had failure developed any significant PI resistance. Here you see a 63P mutation, a 77I mutation. These are not major protease inhibitor resistance mutations, and in all of the cases, people who resumed triple therapy, who added back even weak nucleoside analogs, were able to resuppress. And so the cost in terms of resistance was minimal, and so if you could just about maintain adequate suppression with a boosted PI as a single agent, then maybe doing this with two drugs could be highly successful, and as you saw from the data that Anton showed, that indeed turns out to be the case. But not every two-drug regimen is going to be the same. In this study where Lopinavir, ritonavir with efavirenz was studied as one of the arms, you can see that the two-drug regimen didn't do as well as the efavirenz regimen did, and in fact there was more resistance in the NRTI sparing group compared to the efavirenz compared to the Lopinavir group. So here's triple therapy with Lopinavir, triple therapy with efavirenz, and you can see that in the efavirenz group, 24% of those who had virus available for resistance testing had a 103N, but 55% in the nuke sparing group. Now, why might that be? Well, the drug in the two-drug regimen that people most often interrupted was the boosted PI, because it was the least tolerable drug in the regimen, leaving them on efavirenz monotherapy very likely, and so even more likely to select for efavirenz resistance than if failing the triple regimen with two nucleosides. So then Jose went on to do looking in the OLE study then of the switch to Lopinavir, ritonavir with 3TC. Here there was really excellent success. So this is the follow-on to the Lopinavir monotherapy study. And resistance testing showed presence of a K103N and a 184V at virologic failure in one of two participants from the dual therapy group. So there were only two people in the dual group who failed, and one of them had resistance. Now, this is a Lopinavir, ritonavir 3TC study. Where did the 103N come come from? Obviously, the patient must have had a prior failure on a non-nuke regimen before being moved over to a boosted PI, and now failed again, and not surprisingly had persistence of this mutation and either persistence or reselection of the 184. But that's a pretty good record here. In a respectably sized study, only one participant developing resistance. Likewise, in the GARDEL study, now using the same regimen but as initial therapy, where there was no difference in outcome. There were resistance testing was done in 5 people in the dual therapy arm, 2 of whom had a 184V, and 7 in the triple arm had resistance testing done at failure, and none of them had a resistance mutation. So there was some very slightly increased risk of resistance to 3TC if you failed on the dual therapy, but that's in the context of overall non-inferiority of the regimens, and so it's really hard to say that there was a substantial virologic risk to using the 2-drug regimen in place of the 3-drug regimen. Anton has mentioned the NEAT study as a preparation, well, it's not fair to call it preparation because the NEAT was moving forward, but in advance of the NEAT study, the ACTG did a pilot study of boosted darunavir with raltegravir, a single-arm study to see whether this was a regimen worth pursuing. And as it turned out, in participants who had very high virus loads, we saw striking rates of virologic failure, and those failures were associated with emergence of integrase inhibitor drug resistance, not darunavir resistance, but raltegravir resistance. And you can see there were 23 participants who met the criteria for virologic failure, and I'm sorry, there were 28. 5 of them had resistance, 20 were wild type, and 3 we couldn't amplify. And this turned out to predict well the results of the NEAT study, where although overall there was non-inferiority of the regimens, as Anton already mentioned, at the high virus load, low CD4 group, there was a higher rate of virologic failure, and there were resistance mutations that emerged to the raltegravir among the participants who experienced failure in that study. Small number overall, 400 participants randomized to the dual regimen, only 5 had demonstrable resistance, but nobody developed resistance in the triple arm, and as we know, with newer integrase inhibitors in triple therapy, it's rare to see resistance, so you have to balance the risks there. The SWORD studies, which Anton mentioned, looking at dolutegravir and rilpivirine as a switch. So participants were already virologically suppressed and then switched from their triple regimen to dolutegravir and rilpivirine in 2 similarly designed trials with minimal loss of virologic suppression. Resistance testing in just a single participant who was known to have non-adherence showed evidence of emergence of an NNRTI resistance mutation associated with rilpivirine resistance, the 101K E mixture here, with a very modest fold shift in susceptibility, but no resistance to dolutegravir. And then a slide that Anton already showed you in Babafemi Tewo's follow-on to PADDLE. So recall that the PADDLE study enrolled participants with virus loads less than 100,000. ACTG, and was limited to 20 participants. ACTG A5353 had 120 participants and allowed people with under virus loads under 500,000, so going 0.7 log higher than in the paddle study, and showed, again, as a single arm pilot study, and showed excellent virologic suppression and suppression rates that were comparable whether the baseline virus loads were above or below 100,000. But there were a few people who failed, all of whom had demonstrable non-adherence, and this one participant had non-adherence and emergence of drug resistance. So the red dashed line shows the dolutegravir concentrations, and you can see that when there was measurable or high levels of dolutegravir, there was virologic suppression, but then when the dolutegravir dosing was inconsistent, then you had virologic rebound, and then over time you had emergence of resistance mutations. At this time point, a 184V mutation conferring 3TC resistance, and the sort of canonical dolutegravir mutation that Mark Wainberg first described, the 263K, emerging as a mixture here. Interestingly, at a later time point, only the 184V mutation was present, and again at a time when there was where dolutegravir levels were below the limits of detection. So it is possible to select for dolutegravir resistance in the context of a two-drug therapy if you're not consistently taking the regimen, but it was uncommon. And we'll see the data from the phase 3 trial later this week. Now, in the LATTE study, there were two LATTE studies. LATTE 1 was, which I guess was not called LATTE 1 at the time, it's called LATTE. It's only it's like, you know, World War I was not called World War I, it was the Great War. It was only in retrospect that we called it World War I. So the LATTE, original LATTE study is only now in retrospect called LATTE 1. So in LATTE, which was using oral two-drug combinations of Cabotegravir and Rilpivirine, there were very high rates of virologic suppression that were at least as good as what was seen in a triple drug regimen with efavirenz, but there was the infrequent occurrence of resistance. There was a failure in one participant in the Rilpivirine and 10 milligram Cabo group at week 48 with subtherapeutic levels, and in that participant resistance developed to both drugs, 148R that conferred threefold resistance to Cabotegravir and 30-fold resistance to Rilpivirine, making the point again that the 148 mutation has differential effects on the first generation integrase inhibitors and the second generation drugs. And then two other participants with virologic failure developed resistance to Rilpivirine, but not, in one case, no resistance to the integrase inhibitor, in the other case, it couldn't be tested. Now, LATTE 2, which used the injectable form after an induction period with an oral lead-in, has recently been published with 96-week data. And in this study, there were 3 participants who met protocol-defined criteria for virologic failure in whom resistance testing could be done. One was in the oral dosing arm, and that person had no resistance mutations. And then 2 in the every 8-week injection arm, one of whom had a 269 mixture in integrase, and then one had a number of mutations in reverse transcriptase that confer resistance to Rilpivirine and a Q148R mutation in the integrase gene. So this virus was resistant to all of the non-nukes, to raltegravir, elvitegravir, and cabotegravir, but remained susceptible to dolutegravir. just like to remind people that when used as a single agent, dolutegravir is likely to lead to the emergence of drug resistance, as you can see from this slide adapted from Jose Blanco's review article summarizing much of the resistance data, and particularly you can see in the REDOMO study quite a few people who developed a variety of drug resistance mutations, and then also in the DONOMO study, which we've already heard a little bit about, including this, the emergence of the 155 here and here. So even though 263K may be considered a canonical mutation, it is not the only mutation that can be selected by dolutegravir. So if dolutegravir is going to be used in 2-drug regimens, you want to make sure that the regimens are robust. And Anton showed you the press release stating that no resistance was observed at failure. We'll see the detailed data on Tuesday when the trial is presented, and I think everybody is looking forward to that. So 2-drug antiretroviral therapy can be effective as initial or maintenance therapy, but regimen matters. It's not any 2-drug regimen. It has to be a carefully and wisely selected 2-drug combination. And at least one drug in the regimen has to have a high barrier to resistance, and we can argue later about exactly how high barrier should be defined. 3-TC would never be considered a drug with a high barrier to resistance, but 3-TC combined with a boosted protease inhibitor or a robust integrase inhibitor seems to do the trick. Second-generation non-nukes, when combined with a robust integrase inhibitor, likewise seem to do the trick. What we don't know is what is the impact of pre-existing XTC or NNRTI resistance on the efficacy of dolutegravir 3-TC or dolutegravir Rilpivirine. And then given the risk of dolutegravir resistance emergence with monotherapy, I think it's clearly best to avoid dual therapy when XTC or Rilpivirine resistance are present. So I'll stop there and turn this back over to Jonathan and Bernard.